Thank you. Thanks very much. And thanks very much to the organisers for asking me to come and talk about TB and for such good selection of topics this afternoon, because more so than TB, scabies, rheumatic heart disease, even though many of us working in Brisbane or cities may not see a lot of this, they are diseases that are devastating our neighbours and countries that are very, very close to us and very worthwhile talking about. And thank you also for the communication of the organising committee and the T-shirt and the water bottle, and which is very nice to have. And particular thanks to Grace Liu, who I think made great suggestions for my slides and made them look like much more fun. So TB in children. So TB is an ancient disease. The mummies from 3000 BC, the tubercular decay is obvious in their bones. And Socrates, 300 BC, talked about phthisis, which is the Greek word for consumption, and said it is the most prominent disease of our times, illustrated by coughing of blood and almost invariably fatal. So we've moved on a little bit from then. And this is a Stannington Sanatorium in the UK. This is 1901. And these were so common around the UK and Europe. And the children were all cohorted into age group. And these were all girls, and they all had bony TB. And they looked very well behaved, although a little bit scary person keeping an eye on them there. And everyone thought living out in the open was what cured TB and was good for TB, so much so that Woodrow Wilson, 28th president of the US, said the cure for bad politics is the same as the cure for TB. It's living in the open. But I don't think we've learned much from that. So who gets TB? And these pictures, I think, illustrate which children are getting TB these days in our world. And it's children from high endemic countries, often poor resource countries. The first picture is a child from Africa, and the second is from East Timor. TB goes hand in hand with malnutrition, HIV infection, as well as other infections. But to understand the global burden, this is from WHO in 2010. So the world population, about 6.9 million then, but a third of the world is infected with TB. So they don't have disease, but 1/3, which is a very, very large number, have the infection. They've inhaled the tubercle is in the lungs. They may never get disease. Only 10% of people who become infected with TB actually go on, and hence only 9 million per year only have TB disease. And if we look at the global incidence rates, you can see the countries that are most affected: South Africa and Southeast Asia, and some of our very close neighbors, East Timor, PNG, and other islands there have lots of TB. Russia is a problem, especially with resistant TB, and Alaska also has TB, especially in the Indian population. So Australia, by comparison, has low rates, and this illustrates the drop in our rates from the 1960s to current rates. And some of those countries that I showed in the previous slide have up to 500 cases per 100,000. And some of them, almost 1% of the population have disease. We know 1/3 of the population are infected, but up to 1% have disease. Whereas Australia, the numbers are relatively low, and we're only, instead of being 500 per 100,000, just 5 per 100,000 approximate incidence. And this was a paper published by Cho and published 18 months ago in the MJA, which looked at children over the last 10 years or so, aged 0 to 14. And we can see what children are acquiring TB in Australia. And so even though we would have thought most of the children are born overseas who end up with TB disease in Australia, and then Australian non-Indigenous and Indigenous as well, and they're proportionally larger than the Australian non-Indigenous. And if we look at the states, Victoria had a lot of people coming who were born from overseas, and they had the greatest numbers in this particular study, although in the last 2 or 3 years, it's become evident that we're seeing more cases in Queensland, and many of these are children who may have been in PNG. And it was thought that we might identify children with TB on immigration or immigration screening, but that's actually not the case. Immigration screening identifies relatively few children with TB, and most of them are presenting to our practice with symptoms, and then a significant proportion are being picked up through contact tracing. So we do need to be aware of TB. I'm sure many of you have encountered cases, and sometimes it's quite unexpected, and in children that have been living in Australia for years and you wouldn't expect it. So just to say again, TB infection and disease are not the same. The whole iceberg are people who are infected with TB, and only about 10% will develop disease. And so this is a typical case. What is the risk of a child developing? Let's talk about infection first. So children who acquire infection. And the most important risk factor for acquiring infection is contact of the child with someone who's got TB. And that someone is important. And studies have shown that a child is much more likely to acquire TB if their contact is female, for obvious reasons, breastfeeding and proximity. If the contact has 3+ smear-positive TB or laryngeal TB, when TB is expelled continuously, numerous tubercules into the air. So if we look at this, was a patient we looked after in Timor, a young mother who came into hospital with 3+ sputum-positive TB. And this is her young infant, who actually looks quite healthy there, might possibly have some scabies, because most of the children do. It's very, very, very common. And so what is the risk of this child acquiring TB from his mum? And then that's her Xray. And you can see she's got severe TB with cavitation and 3+. So a very transmissible case. And so if we look at this graph, this shows the proportion of children who acquire TB, develop infection by degree of smear positivity of the case. So a small proportion, if they're in contact with a case that has TB but isn't smear positive and is male, up to this is the most risky scenario, when the person the child is in contact with is 3+ smear positivity and is female. And then in those cases, 45 to 50% will acquire TB. So that baby has a 50% chance of acquiring TB from his mother. So if you suspect TB in a child, how do you detect the infection? And there are two main reasons for detecting infection, not disease, but just that the person has acquired and mounted an immune response. The MAN2 test is the conventional one, when you look at the amount of inflammation in the skin, when you put some antigen intradermally. The thing is you have to wait 72 hours and read the amount of inflammation and see the patient again. Whereas what are becoming more popular now are the gamma interferon release assays, where you're measuring the amount of gamma interferon in the blood that has been produced in response to the antigen. And the advantage of the gamma interferon release assays is that it's just one blood test. Patient doesn't have to come back in 72 hours. And also BCG doesn't affect the results, and most of the non-tuberculous mycobacteria don't affect the result. A few do. The disadvantage is that you must also demonstrate that the patient can respond to a mitogen, and often you get indeterminate results in young children. But these are taking off. They're very helpful, very useful, and we'll see more of them used now for the reasons I've mentioned. So what are the risk factors for TB disease in children if they do get infection? And most people who develop TB infection, 10% will develop disease, and it'll be mainly in young and elderly. HIV infection is a risk factor for developing disease, immunosuppression, malnutrition, and if they haven't been protected from BCG. And if a child does develop disease after infection, it usually occurs in the first 1 or 2 years after infection, but can occur in people up to 30 years later. And if we look at the risk of TB infection by age, a TB disease, so if a child acquires infection, this is the risk that they'll get disease. The PTB is pulmonary disease, so if they're under 1 infected, close to 40% will develop pulmonary disease, and disseminated TB in a smaller proportion. And this is the age group that's targeted for prevention, and BCG is one of the main ways of preventing. This is another way of looking at the same thing. Children under 1 year of age, if they are infected, maybe 50% won't develop disease, 35% will develop pulmonary disease and 10% miliary or TB meningitis. And then if following BCG, you can see there's a little decrease in the pulmonary, this is the old slide, not much decrease in how many get pulmonary disease, but a significant decrease in the number who will get TB meningitis. So we know BCG doesn't really prevent you developing disease or infection, but it will help you prevent you get the worst forms, which is meningitis or disseminated TB. And then if you introduce contact screening and preventative therapy, the numbers getting disease drop even further. So what are the manifestations of TB disease in children? TB can affect any organ in the body, anywhere at all. This is a child with abdominal TB. She's got TB in her mesentery, and it's causing swelling and doughiness of her abdomen. This is one of the most tragic manifestations of TB meningitis with the oppositeness, and you can see this, that there's unlikely to be a good outcome in this particular case. TB of the spine with severe kyphosis, which has been corrected then in this picture. It's pericardial disease and pleural effusions, and then what's quite common is adenitis, TB adenitis. If any of you have time, and you remember this was published last year in Pneumonia, 2016, a whole series of papers on TB, but this is a beautiful 3D graphic of how TB disease occurs from when you breathe in and you get your first GON focus, when the TB multiplies in the periphery of the lung, to a more complicated GON focus, to when you get some adenopathy associated with it, and then you get consolidation, cavitation, and if you've got a bit of time, it's fun just looking through all of those. You'll enjoy it. So how do we diagnose TB in children? Well, history is so important, number one, and the contact. Clinical examination, then seeing if there's any evidence of infection. Chest X-ray is very important, obviously, to see, according to those graphics, if there's any subtle findings of TB disease. And then laboratory diagnosis. Sputum is the mainstay for most cases of TB, which are pulmonary. Very hard to get sputum samples from children. Not many children can expectorate their sputum. The other possibility is induced sputum, where you give them a saline nebulizer and that stimulates a cough. The other is gastric aspirates, where a nasogastric tube is put down and an early morning saline lavage, and you're hoping to acquire then some swallowed sputum that you might grow the TB in. There's the string test, where you can swallow an absorbent material, leave it in the stomach for a while, pull it up, and then even just NPA sometimes. And then so we can try all those methods to get sputum from children, but it's difficult. And then there are other specimens that one can take, depending where the TB is. And always to remember, in any case of TB in children, to do an HIV test. And when you acquire your specimen or your sputum, culture takes 6 weeks. You can look under the microscope to see if you see acid-fast bacilli. But this gene expert diagnostic technique has revolutionized the diagnosis of TB, particularly in poor resource countries, because this little machine, and you just put the sputum in this box and put it in within 2 hours through nucleic acid amplification methods, the NAT test or PCR test, you may identify the TB microbe, and at the same time it can identify whether the rifampicin resistance mutation is present, so you know within 2 hours sometimes whether you have TB and whether it's resistant or sensitive. So I'm just going to go through a few cases that we've had here in Brisbane recently. This was a 13-year-old girl from PNG who came with fever, cough, weight loss, and this was her X-ray, and coming from a high endemic country, you would suspect TB. She was easy because she could expectorate sputum, and numerous acid-fast bacilli were seen in the sputum. Her MAN2 was 22, although a positive MAN2, of course, doesn't diagnose disease, it just diagnoses infection. And then her PCR was positive. And she had when we contact traced her family, she had a sibling who also had positive sputum, so had disease. She had 3 siblings who didn't seem to have any disease, but all had positive MAN2s, and there was an infant young brother in PNG. So the repercussions of one case are large. This was a 5-year-old refugee from the Congo who presented with cough. He doesn't have obvious findings on his X-ray, but if you look closely, you can see opacification, 3 little nodules of opacification here, and has got lymphadenopathy. And so this is the GON focus, and the complex, the Ranke complex, is the GON focus with the adenopathy, which is also evident according to the radiologist. I have to say I don't see it that obviously myself, on the lateral X-ray. And this is primary pulmonary TB, and this is a post-mortem sample where you can see the GON complex on the periphery of the lung, and then some infection here at the hilum in the lymph nodes. And the signs of symptoms are infrequent: fever, cough, night sweats, failure to thrive, some wheeze, and often not a lot in primary pulmonary TB. This was another boy that presented to Brisbane, a 4-month-old Samoan boy. And Samoa isn't a place with high prevalence of TB. And he had had a month of fever and had gone back and forth to GPs and to the local hospital. People had thought it was a viral illness or other infection. And even when this X-ray was seen, which looks typical in retrospect, because TB isn't at the forefront of people's minds, especially for someone who's been born and parents have spent most of their time in Australia. But this does show miliary TB. So, so all the, I have to work out how to go back. All the little milia are like little millet seeds, and they all represent micronodular infection with TB. And when we looked at his family, 24 family members had infection. His father had been coughing blood and was thought to have swallowing nosebleeds and that for the previous 6 months. And so the father had infected 24 family members, and 5 had pulmonary disease. But if you don't encounter TB, often you won't think about it. And this is another example of miliary TB, and post-mortem again, you can just see it. Miliary TB represents a massive lymphohematogenous spread of massive amounts of organisms, and so you will inevitably find TB elsewhere, often in the brain or elsewhere, as well as the lungs. Chronic pulmonary disease is slightly different, and often up in the apices you get cavitation and infection, and sorry, horrible photo, but it just shows the extent of infection and how sick these patients are. Pleural effusion, pericardial effusion. And then TB meningitis is, one of the tragic manifestations of TB, high mortality and morbidity. Often your MEN2 is negative, your chest X-ray may be normal. But and even the cerebrospinal fluid, when you do an LP, can be misleading. Often you may not have elevated cells in the early stages, but one thing that becomes typical later on is a very low glucose and a high protein, and you get this thick exudate all around the vessels of the brain. So how do we treat latent TB? So typically we used to give 6 or 9 months of oral isoniazid, and now we've changed to a shorter duration of combined treatment with isoniazid and rifampicin for 3 months. Not everywhere has changed. Queensland has changed over, Western Australia has changed over, and this is a more practical way of treating latent TB, and there is a Queensland guideline available on the internet. How do we treat disease? Usually 6-month course, that's the standard length of therapy, and if we can, directly observe therapy. And the first-line regimen involves 4 drugs in the first instance. Once you know that your bug is sensitive, you can drop ethambutol. But isoniazid is a high-impact drug that's useful for killing rapidly multiplying bacteria. Rifampicin is good for sterilizing. It has a longer duration of action and is good for eradicating over the long period. Pyrazinamide acts on the bug in acidic vacuoles. So combining and ethambutol is good in case there's resistance. So combining them all is effective. And again, there's a Queensland guideline. If a child has TB meningitis, we extend to 1 year. Who do we give steroids to? And if we do give steroids, it's usually about 2 up to 4 milligrams a kilogram actually for 4 to 6 weeks, and then taper over 1 to 2 weeks. We recommend steroids for all cases of TB meningitis, and then consider it for the others: compressive lymphadenitis, severe miliary disease, effusions, endobronchial and abdominal TB, but give to all meningitis cases. And just in the last couple of minutes, I'll just say a couple of words about multidrug-resistant TB. And this is an enormous problem, an emerging problem throughout the world. And when we look at the map, You can see where the pockets of multi-drug resistance TB are, a lot in the previous Russia, Soviet Union, because TB was common among the prison population. Patients weren't treated properly, they weren't given full length, they were crowded together, and there was rapid transmission. And the same that's happened in Southeast Asia and particularly South Africa. And Peru is I don't know if any of you have read Paul Farmer's Mountains Beyond Mountains, fantastic book about his efforts in Haiti, but he was also involved in one of the first steps in recognizing multi-resistant TB. The governments of Peru didn't want to recognize they had multi-resistant TB, but it spread, and hence it's one of the countries that has one of the greatest prevalence. And some TB, if it's extremely drug resistant, is untreatable. And what happens is you get one resistant bug mutates amongst all the bugs, and then you give an antibiotic, all the others die. This is what happens with all antibiotic resistance. And the resistance bacteria multiply, then become more common, and you end up with a resistant bug. That's one way of getting resistant TB. The other is by transmission, being close to someone who has resistant TB. This is a patient we're treating in Timor with multi-resistant TB. The problem with MDR TB is up until now, the total duration to treat it was 20 months of therapy, and at least 8 months of that involved an IV drug, usually amikacin, an aminoglycoside, and often the patients have to be in isolation during that time. And you need 4 effective oral drugs then when you go on to the 16-month continuation. There is a new Bangladesh regime, which is 9 months of therapy only, which we are embracing now in Queensland and elsewhere. So it's a big deal, MDR TB. So we need to remember TB is common worldwide. We need to be aware of it, try and recognize it. If we happen to have a case, think of it at least and test for it, or ask particularly about contacts. But it's a very big problem in our neighboring countries. It is difficult to diagnose definitively in children, so often we would make the diagnosis based on symptoms. MDR TB is a growing concern. We should try and treat latent TB, recognize latent TB or TB infection, especially in the under 5s and those who are in contact with MDR. Chest Xray, sputum, and HIV testing, we need to remember all of these. Thank you.